All right, folks, it is 6 o'clock. Thank you for joining us today. We are so lucky to have Dr. Franklin Wright, who is one of our amazing trauma surgeon, critical care surgeons at the university. I'll let him introduce himself, but he will be talking a little bit about trauma management. So I will turn it over to you.
Thank you, Dr. Farkas. Appreciate it. Welcome, everyone. Yeah, my name's Dr. Franklin Wright. I'm trauma acute care, surgical critical care at the University of Colorado. Did my residency here, did fellowship out in Chicago at Loyola, and have been back on faculty for about 12 years now. Um, and initially was asked to talk about traumatic arrest. I think it's really hard to talk about traumatic arrest for a full hour, hour and a half. So I tried to incorporate some other things that I thought were relevant concepts in pre-hospital trauma care. So I will warn everyone, I am on ICU call for this entire week. So on the off chance that somebody calls me, I may have to briefly go on mute and answer a clinical related call. But if that happens, I will try to give you a heads up. Let me go back to sharing. My second monitor is not working for some reason, so I will probably not have visualization of the chat while I'm talking. So um, feel free to interrupt or ask questions if something comes up that I can answer in real time. Otherwise, happy to go over things at the end. Also, let me yell at my dog. Okay. So concepts tonight are that we'll go over. There we go. I'll start with kind of an overview of the mechanisms of trauma and what I think are some critical important differences between blunt and penetrating trauma and subtypes even within those, and how mechanisms can really point us to injury patterns and things that we need to be aware of in our trauma patient population. I'll then focus on chest trauma. So not only is how patients got injured critically important, but where they got injured is a critical point. So we'll go over a number of important concepts that tie into this overall increasing trauma survivor rates. And there's a fair amount of that in the chest trauma world. So we'll go over some specifics there. We'll talk about hemorrhage control and also include some damage control resuscitation concepts and a history lesson and overview of how concepts in trauma care have really shifted over the last 20 or 30 years. Uh, Traumatic arrest, we'll talk about again as kind of the overarching concept. We're trying to prevent a lot of these traumatic arrests, but we'll talk a little bit about traumatic arrest. And then finally go into some detail on resuscitative thoracotomy and what that looks like and who gets it and what the data are on that. So hopefully that'll fill up a good chunk of time. So starting with mechanisms of trauma, everything in trauma, actually blunt and penetrating, is just transfer of kinetic energy, right? So remembering back to physics, it's kinetic energy is 1/2 mass times velocity squared. Well, it's the velocity squared that really gets you most of the time. That's absolutely true in motor vehicle collisions. Massive vehicles matter a lot, but by squaring the velocity, that's really what imparts a lot of force to the human body. And we'll talk through a little bit more specifics on why that matters with types of impacts, even within the general field of MVC. Fall. Trauma world is shifting in the last 20 years. We've gone from much higher rates of MVCs, that injuries with significant injury with MVC, put it that way, and we're seeing a lot more and more elderly fall injury, and the curves really are crossing where MVC serious injuries going down year over year and fall injuries are going up year over year. So, but we'll focus a little bit more on the more interesting high falls from height and talk a little bit about how that mechanism affects things, and then auto versus pedestrian, auto versus bike, etc. Some of the injury patterns and mechanisms associated with that. So, how cars impact matters. So, head-on collisions have a higher mortality rate. And some of these data are older. And again, with improving safety of cars, um, we're seeing lower overall rates. But looking at patients who die in MVCs, patients are more likely to die in a head-on impact than in other kinds. So then the obvious reason for that is back to the 1/2 mv squared. It's the velocities compound, right? And so when you're hitting a car head on, it's the velocity of your vehicle hitting the velocity of the other vehicle coming towards you. So even though there's a lot more protection on the front of cars, the overall energy transferred to the car and then to the human body is a lot higher. Side impact makes up another decent chunk, and a good portion of that is because now there's, we're not compounding velocity, but there's a lot fewer protections. Newer cars have some side impact airbags, but again, there's 4 to 6 inches of vehicle between you when you're on the side compared to many feet of crumpling metal on the front. So side impacts still carry a fairly high mortality. Rollovers are quite impressive, but again, as long as the cage of the vehicle holds intact, they actually make up fewer of the mortalities than even the side impact. And then rear end, it's, excuse me, less common again, unless you're at a dead stop getting rear-ended. If there's 2 cars moving, which we do see, but if there's 2 cars moving, the relative velocity between the two is lower. So the lateral impact I mentioned with the side impact, there's less protection from the car. There's a high rate of thoracic and abdominal injuries with that side impact mechanism. And then absolutely the worst is being ejected. And this is, seatbelts do a lot of important things, but literally just even if all the seatbelt did was keep you in the car, they would still be beneficial. Yes, we've all heard or seen stories of somebody that gets thrown from the car and is miraculously unhurt, but that's miraculously unhurt for a reason, because these tend to be the most injured patients. There's a lot of safety mechanisms built into cars, and the moment that you are thrown out of the car, none of those safety improvements make any difference. So now you're moving at the speed the vehicle was moving when you're thrown from it. You're highly likely to hit something that's not going to move, and you have no protection. You have no crumple zones, you have no airbags, you have no restraints. So, when we've looked at this, and there's good literature on this, that these patients have a much higher mortality rate, a higher injury severity score, which is a way in the trauma surgery world that we quantify how seriously someone is injured, and a much higher ICU admission rate. So we're talking 4 to 5-fold worse outcomes in patients that are ejected. So definitely gets our attention in the trauma bay when we get report that someone was ejected from a vehicle, because we are highly concerned that they're going to have significantly worse injuries than patients that have been restrained, even in very crumpled cars. Moving on to falls, we refer to this sometimes as LD50 or LD90, and so this comes from pharmacology when we talk about lethal doses, right? So the lethal dose is the amount of medication or poison that someone takes that kills half the people that take it. So that's an LD50, it kills half the people. LD90 is the dose that would kill 90% of people that took it. So when we think about it in terms of falls, height matters, obviously, but in bigger studies, the lethal dose, the point at which half of patients will die from impact, is about 48 feet, so about a little more than 4 stories. How you fall also matters. The photo on the right is why we see more male trauma than female trauma, because we seem to think things like this are a good idea. But how you fall matters. So if you fall head first, in other words, if the injury patterns when patients come in are primarily to the head or chest, then the height at which that is fatal is lower. It's 3 stories, 34 feet. If you manage to land feet first, then that height goes up to about 68 feet. So again, if you don't primarily impact on your head or your chest, then your mortality is, and then you can fall from a lot higher before half the people are going to die. Once you get to 7 stories, it's nearly universally fatal. Again, not always. That's 90% of people will die. Now the question becomes, what other significant, just because you don't die, unfortunately, doesn't mean you're not horribly and permanently injured, whether it's brain, spine, etc. But at least you have a 10%, even up to 7 stories, have a 10% chance of living through it. Questionable what that life looks like sometimes. high rate of orthopedic injuries, again, fall from any height, a lot of orthopedic injuries. Spinal fractures are also very high. The people that are lucky enough or skilled enough to land feet first, there's some kind of classic injury patterns we look for. So calcaneal fractures. So if the heel bone fractures, first of all, that takes a lot of force because it's a giant, relatively round bone. So it takes a lot of force to fracture your calcaneus and tends to be a fall from a pretty decent height. The problem is if you've broken that calcaneus, that force is transmitted through your skeleton all the way up your spine. There's a very high rate of spine fractures especially with kind of fall onto feet because that force is transmitted up through the spine. Number of other kind of injury patterns. So that calcaneal fracture I mentioned, the pelvis is another one that's very commonly injured. Not only does the force go through the spine, but also goes through the pelvis. And we'll talk later on about some pelvic fracture injury patterns that certainly apply with falls. Chance fracture are those spinal fractures that we talked about, compression fractures from landing on the feet. Traumatic aortic injuries we'll also talk about, and then certainly traumatic brain injury from falls from any height, especially if we're not landing on our feet. If there's any head impact with the ground, the TBI rate is pretty darn high. So finally, in kind of the blunt world, we think about kind of auto pedestrian. The kind of classic injury pattern here is, and this is starting to shift with larger vehicles, higher bumpers, higher hoods. So we're actually starting to see it. It used to be a lot more kind of tibia and fibula. We're starting to see more knees and femurs as bumpers and cars have gotten bigger. We're seeing more higher lower extremity injuries. Problem is, once you kind of hit that hood of the car, often then you're kind of fulcrumed up once the bumper hits, you're fulcrumed up onto the hood and then into the windshield. So also a pretty high rate of thoracic of chest injuries and then head injuries from being thrown onto the hood, slamming onto the hood, and then head hitting the windshield of the driver's car. So again, kind of classic patterns: a tibia, fibula, sometimes femur, and then a lot of rib fractures, TBI, and then solid organ injury. Again, this kind of whipping motion artifact and slamming your thorax and abdomen into the hood of the car can lead to solid organ and like spleen and liver injuries. Spleen and liver injuries are the most common, or the big solid organs in the abdomen, and the most commonly injured intra-abdominal organs when things are going to be injured. We can certainly see bowel injuries and mesenteric bleeding and things like that, but the most common organs that are injured in blunt trauma are going to be spleen and liver. So moving over to penetrating trauma, I'll talk through a little bit about some of the differences between shotgun, handgun, rifle, and differences in ammunition types and how this kind of matters to the human body. That top picture is a cross cut of a shotgun shell, and we'll talk through that a little bit. But there's a lot of different ways that a bullet can be manufactured. And that matters in the sense of the amount of tissue damage that they can create. The velocity really matters, so we'll talk about some of those differences between kind of handguns and rifles. Shotguns are a little bit their own beast, so we'll talk through some of that as well and go over why these things matter. So, as I mentioned, shotguns, a unique injury pattern because it really is very distance dependent in a way that handgun and rifle injuries frequently aren't. And the reason for that is they're spherical pellets by and large. There are slugs that you can put in a shotgun shell, but that will behave much more like conventional projectiles. But the vast majority of shotguns have pellets in them, whether it's birdshot, which is a lot of really small pellets, or buckshot, which is fewer, bigger pellets. They're spheres. They come out of a non-rifled bore, so rifling in a handgun creates spin on the bullet, and it helps it keep its trajectory more linearly. With smooth-barreled shotguns, the pellets come out and instantly start to spread. So this picture is kind of the cone of the pellets spreading over distance. That matters because spheres actually don't retain velocity very well. And again, a lot of what we're looking at for how much injury something creates is its velocity. So as that pattern spreads wider and wider, the pellets are going slower and slower. And so we can see the effects of that on the human body, where if you look at the human body, so 25 centimeters, so that's about 10 inches. So if the injury pattern of the pellets is bigger than about 10 inches, the chance of internal injury of those pellets penetrating deeply enough drops off quite dramatically. So if someone is within 5 to 10 feet of a shotgun that goes off, those pellets are going quite deep because they still have a lot of velocity in them, but there'll be a relatively small pattern of pellet entry at skin level. Once you've gotten beyond 15 or 20 meters, so again, 50 to 65 feet or so, the pellets don't tend to penetrate very deeply, and often they'll end up kind of trapped in the skin and muscle and not causing serious injury. So the difference of the top is the entry site on that patient in the top into the chest. Big hole, but even the small pellet holes around it are in a pretty small area. And you can see the kind of chest x-ray on the upper right that demonstrates from that is those pellets hit bone and scattered, and they certainly internally scattered beyond, beyond 8 or 10 inches. But the actual skin entry site, this was somebody that was relatively close to the shotgun, and you can see the kind of catastrophic damage that did to the rib cage and into the chest cavity. Picture on the bottom, a lot of holes, but peppered over an entire back, right? So this was from quite a distance away. That chest x-ray on the bottom right, pellets extending across the entire thorax, but if you notice, no hemothorax, no pneumothorax. These pellets didn't actually make it into the pleural cavity and into the area where we worry about significant injury. So looks horrible and a huge spread, but actually much less dangerous to the patient because these small pellets, and these are also birdshot. You can see there's a large number of those pellets in there. And so they did not penetrate very deeply at all. In general, and this applies a little bit more to rifles than handguns, but in general, longer barrels have a greater velocity. And there's obviously a lot of exceptions to this rule, but the concept behind this, and there's certainly kind of a maximum that becomes true. But back in the old days, in the colonial days, we used black powder, right? And even up into the 1800s, we used black powder. And black powder is an explosive, which is why armories would sometimes explode during the Revolutionary War, is because black powder is an explosive. Gunpowder is not. Gunpowder is a propellant. So when we ignite gunpowder, it releases gas very quickly, and gas pushes the bullet down the barrel. And so, yes, there's a muzzle flash from that gas burning off, but it's not actually an explosive reaction, it's a gas propulsion reaction. And so, a longer barrel, within limits, certainly allows more time for that gas to propel that's trapped in the barrel to propel the bullet at higher speeds. Now, different powders and different, a lot of these have a maximum limit where, a 16 or 20-inch barrel, if you go beyond that, the gunpowder will all have burned off before the propellant leaves. But if you have a very short barrel, some of that propellant is wasted because it's starting to push the bullet out, but then the bullet leaves the barrel and now the propellant dissipates into the air and you get a big muzzle flash, but you're not actually pushing the bullet as quickly. So that plays a big difference in creating velocity, which is part of the reason that rifles in general will create a lot more tissue damage than handguns, is that the velocity out of a rifle is a lot higher. Now, certainly the rounds have more powder. They're designed for longer barrels so that they can launch the bullets at a higher rate of speed. And once a bullet leaves the barrel, it does begin to move. So even with the rifling that's trying to keep the bullet spinning like a football thrown in a spiral pattern, there is bullet movement within the air. It yaws, it rolls, and it pitches. And interestingly, once bullets enter tissue, and as shown in this kind of top gel diagram, they actually tend to rotate within the body and fly backwards. So this top one is a 38 special. So it's kind of a standard handgun round, about the same size as a 9mm. And you can see that as it enters a gelatin model that's supposed to demonstrate human tissue, It creates this temporary cavity, permanent cavity that we'll talk about. But the permanent cavity is literally just what the bullet dives through, what tissues it directly destroys by driving through. The temporary cavity is an area where because of the speed of the bullet, it's creating a wave around that injures tissue, even if the bullet doesn't directly strike it. And you can see in a 38 special, the velocity out of the barrel is about 788 feet per second. The bullet itself weighs 158 grams. It will roll, but that temporary cavity is relatively small. The permanent cavity is relatively small. 45, which is another conventional handgun round, is a heavier bullet, so it weighs 230 grams, so it picks up its kinetic energy from the weight, has a decent amount of powder, so still comes out at a pretty good speed, 869. But again, that temporary cavity is relatively small. It's a heavy, relatively fast bullet, and so it just kind of continues along in its path. Whereas the third one down is the classic kind of M16 round of a 5.56 NATO, a 7, or why am I blanking on the 223 is the American version, so 0.223 inches, which is equivalent to 5.6 millimeters. The interesting things about this round is instead of now looking at 800 feet that it's coming out of the barrel, it's coming out at 3,000 feet. It's also a really light bullet, right? And so part of the reason it's going so fast is it's only 55 grams. So it's a third of the weight of a 38 special and, a fifth of the weight of a 45, but it comes out very quickly. And you can see that temporary cavity is quite big. The other interesting thing, because this is often, you can be used as a hunting round, but is also used in military conflict. In military conflict, by Geneva Convention, bullets have to be full metal jacket coated so that they're not designed to deform or expand within tissue, because people agreed that was inhumane. It was creating too much wounding. So again, in military conflicts that participate in the Geneva Convention, I'll put it that way, bullets should be full metal jacket. But one of the interesting things, which means kind of coated with a jacket so that in theory they're not deforming. But one of the interesting things about this round is it does tend to fragment even when it has the full metal jacket applied. And so it often will fragment in tissue when it hits bone in a dramatic way. And that's why that permanent cavity, all that black in the middle of the third diagram there, is so big, is because when that bullet fragments within, first of all, it's coming in with a lot of energy, and now it essentially breaks apart in the tissue because it's such a high energy light around that it will fragment within tissue even when it meets Geneva Conventions and create significant both permanent and temporary cavity damage. And then finally, it's the final round is the 7.62, which is another hunting / military round. So that's the same as a 30-06, or a 308, I should say, not a 30-06, that has more powder, but a 308 caliber hunting round. So a very common hunting round in North America, also known as the 7.62, and that's the bullet that, for instance, an AK-47 would fire. So that is a heavier bullet, so it's triple the weight of a 5.56 round, but it still comes out at a shockingly high velocity compared to a handgun, right? So it's still coming out at 2,600, 2,800 feet per second. And this is why these rifle rounds, I'll call them, create such profound damage to the human body, is the amount of velocity they have. Even if the bullet is not bigger, I mean, the 5.56 round or 5.6 millimeter round is literally not barely bigger in diameter than a 22 caliber bullet. It's a little bit longer, weighs a little bit more, but it comes out at such a high velocity that it creates incredible amount of tissue damage. And so, for instance, a bullet going through the liver instead of a single hole through the liver, like we'd see with the handgun round, now it looks like the liver has been hit by a sledgehammer, and that tissue force literally causes an explosive force especially within solid organs within the human body. And that's why the velocity and particular rounds that are fired really do matter to us in the trauma world. It's very different, and you can't often tell from looking at the skin. The size of the hole in the skin is not going to necessarily correlate with the internal damage. It matters much more, what the velocity of that round was. So I kind of started talking about this permanent cavity, the temporary cavity. So you get the laceration crush, and that's just the bullet going straight through. But then you also get this temporary cavity, which is much higher in high velocity rounds, where you get a stretch and this kind of cavitation effect. And then finally, you get this shock wave, and the shock wave is especially important anywhere near fluid-filled organs, because we can get really high, up to 200 atmospheres in high-velocity projectiles. And these are kind of some wounds that we've seen through the neck, and I don't remember where that one on the bottom right is, but you can see how you can stick fingers through, right? This is a single, again, pretty small bullet, but because of the velocity at which it travels through, it creates this huge tissue zone of destruction that's visualized in those pictures down below. The other thing that we always have to remember is bullets travel. And so we had this patient that came in with a gunshot wound in kind of the right upper chest. You can see on chest x-ray, there's a little haziness on the right. There's a little bit of fluid. There's not a huge obvious pneumothorax there, although you can start to see a little pneumo around the side, but doesn't look that horrible. You see some rib fractures and some fragments. Problem is, if you don't look further and get a chest x-ray that includes the neck, well, turns out that bullet that went in the chest ended up in the neck. And that happens not infrequently, right? So we've always got to be thinking a body cavity of at least a body cavity above or below where the bullet holes are. The other rules of thumb that we always have to think about is we do, part of the trauma survey is rolling and looking for every hole. We've got x-ray once we hit the trauma bay, and we are x-raying to try to make sure we're not missing bullets that have escaped from one body cavity to the other. But the rule of thumb is that the number of holes plus the number of kind of intact bullets that we see on x-ray has to be an even number. So in other words, if you've got a single hole in your chest, if I shoot that x-ray, I'm expecting to see all the pieces of a bullet or a solid bullet on x-ray. If I don't, then I'm missing something, right? Maybe it traveled, into more than one body cavity away. Maybe there's a hole I'm missing. If I see two holes and shoot an x-ray and see an intact bullet fragment, again, I'm missing something. There should, if I've got one hole, if I've got two holes, that could have been a through and through, and maybe there's a couple little fragments, but the bullet went through and through the body. But if I've got two holes and an intact retained bullet, then that means there were at least two shots that happened in general, right? Then we get into some exceptions where it kind of crosses creases or skives, and there are situations that can fool us, but it's a really good rule of thumb to start thinking about, what am I missing? Because bullets can go through and through. In some ways, that's wasted kinetic energy, because when the bullet, leaves the body, any energy that it had to leave the body is now, gone, and it's spent that energy leaving the body, and now it's not imparting into tissue. Whereas bullets that have come to rest in the body, all that kinetic energy the bullet had is been trapped by the human body. This is not a political statement. This is a podcast I love. And so don't take this as political, but the joke is guns don't kill people, blood loss and organ damage do, right? And that's kind of what we're talking about, is bullets, the real damage and the velocity matters is the amount of organs that it damages, either by that secondary wave, or by directly damaging blood vessels and leading to blood loss. So moving on to other forms of penetrating trauma, stabbings, location matters. A decent amount of our stab wounds are kind of on the anterior abdominal wall, and a surprising number of those actually don't need an operation. An example in that right upper picture, that clearly needs an operation. There's intestine poking through, so that needs to go. But a decent amount of penetrating wounds don't actually penetrate through the entire abdominal wall, through the fascia, and into the intra-abdominal space where they can injure things. Even if they do, depending on where they're stabbed matters. In the right upper quadrant, the liver is somewhat protective. You can stab the liver, it may bleed a little bit, but often that bleeding will stop and doesn't necessarily need an operation. Once you get back around the flank, and the back, it's harder because a lot of those are retroperitoneal structures that are going to be really hard to pick up. They may not cause peritonitis and gross instability. They may be initially contained in the retroperitoneum, but they don't always stay contained. So we really need a CT to look at those. Surprisingly, being stabbed in the chest tubes alone will treat hemothorax 85% of the time, and that's for at least stabbing penetrating trauma as well. So simply draining the blood out of the chest and will frequently be the definitive management for stab wounds to the chest. Obviously, this is not always the case, and we have to be prepared to deal with it if bleeding is high volume or persistent. Location also matters because there's something that we call the cardiac box that basically goes from the midline along your clavicles, from the clavicles all the way down to the bottom of the rib cage, and really any stab penetrating injuries in that area carry a decent risk of injury to the heart or great vessels. And so those certainly get our attention. Any stab wounds in that area, we have to be pretty concerned are going to be high risk injuries. And then extremity, which is the photos, I don't remember why I had thoracoabdominal, but extremities. So this is an example of a stab wound to the arm that was a brachial artery injury. And sometimes these present in a delayed fashion. So this was a patient that was actually seen in an ED somewhere else after a bar fight and had pulses in his wrist and was actually sent out from the ED. It wasn't actively bleeding. He had a pulse that they could feel there, and they sent him out. And he randomly showed up in our trauma clinic like 2 or 3 days later because his hand felt cool to him and was really hurting him now. And he at that point no longer had flow through his hand because he'd had a brachial artery injury that had now occluded, and the collateral flow that was allowing blood flow to his hand was rapidly diminishing. So those need to be fixed as well. And sometimes they are not actively bleeding out, squirting. And so we have to be a little more sensitive. Just being able to feel a pulse is not always definitive that there is not a significant vascular injury. The neck is a particularly critical area to be worried about. So obviously there's a lot of vital structures running through the neck, whether it's your airway, your esophagus, your carotid, your blood flow to and from the brain, carotid or jugular. The airway can be quite intimidating. This is one that is scary because air bubbling out of the neck wound gets all of our attention right away, right? That suggests that there's a aerodigestive injury and often an airway injury. It can go very poorly when we try to intubate. So even once they've arrived into the emergency room, sometimes I'm talking down our colleagues from intubating in the trauma bay, saying, let's try to get this patient up to the OR. So if they have an isolated stab wound to the neck and air is bubbling out of their neck, if we want to intubate them, the first thing we're going to do is lay them flat. What these patients do, because it's a self-protective instinct, right, is you put them in a stretcher and they're going to be sitting bolt upright, leaning forward, right? They're trying to let the blood flow out of their airway. And often they're able to maintain their airway by sitting up and leaning forward. The moment that we try to intubate them and give them drugs and lay them flat, now they're drowning in blood and secretions. And it can go very poorly very quickly. If we can't get the airway, now we're doing a surgical airway, but we're doing a surgical airway now through a field that is filled with hematoma and active bleeding. So if at all possible, and there's times when it's not going to be possible, if the patient cannot move air, we're going to have to try to intubate them. But if we can let them control their own airway and try to put some pressure to control some bleeding, I would much rather do all of this in the OR. So we will often get them up to the OR, letting them tripod, letting them sit upright, and literally prep and have all the instruments we need to explore the neck rapidly, so that the moment that We are intubating them. In the OR, when it goes poorly, which is what we anticipate it's going to do, we are ready to get into the neck as quickly as possible and with all the equipment that we could need to get hemorrhage control and better retractors and better lighting and all the things that we have a little more control of in the operating room. Also, this may be the time to, certainly things like glide scope and video assisted may be helpful, but being prep draped, having some fiber optic options to try advanced intubation maneuvers are potentially going to be very helpful in stab wounds to the neck. So moving on from kind of the overall blunt penetrating, moving on to the chest trauma. And the reason I think this is a key one is there's a lot of life-threatening injuries that we can address with chest trauma. Right, so we'll go through this kind of laundry list of problems that we can address in the, a lot of these we can address in the field, at least in some form. So tension pneumothorax, open pneumothorax, massive hemothorax, aortic injury, flail chest, and then finally cardiac tamponade are all chest-based injuries that can all be immediately life-threatening, and there's things we can do about it. So tension pneumothorax, I mean, we show these x-rays with huge mediastinal shift. These are x-rays that really shouldn't be done. This should be a clinical diagnosis where, and that's easier said than done in the back of a rig and, with a lot of noise. So it can be hard to hear if someone's not moving air on one side of their chest. But if we have suspicion, this is something that we can treat rapidly, right? We can do a needle decompression, whether it's in the second axillary space, which is kind of the old teaching, or generally we're shifting to doing it in the same place we would do a chest tube and kind of third, fourth intercostal space, mid-axillary or anterior axillary line. Or even just a finger thoracostomy is the other thing. Making a small incision and kind of bluntly getting our finger into the chest will allow us to vent. So it's essentially that's the step we would do to put in a chest tube. But instead of finishing, we will eventually put in a chest tube, but just popping into the pleural space and allowing air to ventilate out can be an immediate life-saving maneuver. Open pneumothoraces, so big wounds, your machete wounds, your boat propellers, things like this will create these large wounds that directly communicate into the chest. Again, kind of the classic old school teaching was a three-sided dressing on that. So you put a occlusive dressing, but you only tape it on three sides. And the idea with that is that that occlusive dressing gets pulled into the wound when they take a breath in, so it doesn't suck air from the outside world in. And when they exhale, it pushes some of the air in the chest out and lets it kind of flutter through that three-sided dressing. That's still physiologically a great concept, and I think can work well. Once if we have a little bit more resources or expertise than just covering that wound completely for all four sides with an occlusive dressing and venting the chest with a separate incision with the tube thoracostomy, is the slightly more definitive method of treatment. These patients are frequently going to need some chest wall reconstruction anyway, but in terms of the immediate threat to life, we want to drain air out of the chest, because the problem we get into with pneumothoraces is, especially with underlying lung injury, is that air is leaking out of the lung and into the chest, and that air then gets trapped in the chest. And again, with a closed pneumothorax, which is much, much more common, gets trapped in the chest, and with every breath in, more air escapes, and eventually that puts more and more pressure so that the lung can't fully inflate, and it actually starts putting pressure on the heart and great vessels and kinking off the blood supply, the blood return to the heart, which can lead to arrest. So we want to prevent that by decompressing that chest. The open pneumothorax, the same kind of concept with air building up in the chest, but now with a big open wound. When we breathe in, when we are not being ventilated or bagged, if we're spontaneously breathing, when we breathe in, the way that we inflate our lungs is a negative inspiratory force and actually a negative intrathoracic pressure. So if you have a big open wound, when you breathe in, you're actually the low pressure in the chest is actually going to pull air from the outside world into the chest. And again, with every breath, it's going to further collapse the lung. So those are the concepts behind why these pneumothoraces can be life-threatening, and that we need to have a low index of suspicion and intervene early on these. Massive hemothorax is certainly life-threatening. The cutoffs I put are kind of our cutoffs for going to the OR. So, the literature generally quotes once we drain about 1.5 liters out of the chest within a very short amount of time, we need to be in the operating room because that's bleeding that is not as likely to stop on its own and is often surgically correctable. We have a little different threshold between blunt and penetrating trauma. A lot of trauma surgeons will use a little bit lower threshold with penetrating trauma. And the reason for that is often with a crushed chest, a lot of this bleeding is kind of raw surface bone bleeding, a bunch of kind of torn muscle that is actually relatively hard to stop surgically because it's just kind of raw surface bleeding. And so it's not a big vessel that you're going to tie off. And we see that a lot more with kind of chest crunch blunt injuries, whereas a stab or a gunshot tends to be a more linear tract. And if we're getting this much blood out, it's likely to be a focal lesion that we actually can control surgically. So the conventional teaching is about 1.5 liters, quote, initially or within the first few minutes. But then there are additional criteria. We normally say about 200 cc's an hour per hour for multiple hours, classically for 4 hours. So even if they only put out 0.5 liter, but the next hour they put out 250, and the next hour they put out 300, we're going to be thinking we're going to be more likely to be successful getting this all stopped in the operating room. My flail chest video looks like it's kind of green. I have it again later in the talk, so hopefully the other one shows up. But flail chest, we'll talk about a little bit more. I thought I talked about that a little bit more, but flail chest comes down to, and in fact, I know I talk about flail chest, so I'm going to come back to flail chest a little bit later. Blunt aortic injury is a major cause of mortality. So if we want to think about traumatic arrests, blunt aortic injury is way up there on the list. So kind of the seminal paper on this was Lieutenant Colonel Parmley back in the 50s that looked at an autopsy study of blunt aortic injury. A lot of these patients died in the field, and we actually think a decent percentage of people that are trauma arrested in the field are probably due to blunt aortic injuries. But not everyone dies, so 15% will show up with vital signs, and we'll talk about kind of why blunt aortic injury happens and how we can be thoughtful about diagnosing this and dealing with it. So blunt aortic injury, the big three mechanisms of how aortas are injured with, again, conventional, focusing more on the blunt trauma side, is a deceleration injury, compression injuries, or intraluminal hypertension. So I'll go through each of those. So the deceleration are these kind of shear forces. So part of it is, the sternum is compressed, the root of the aorta torques, and you get a lot of bending and shearing, especially at the ligamentum arteriosum. So that's the embryologic remnant of when we were in utero, we had a connection between our pulmonary vasculature and our systemic vasculature, the ligamentum arteriosum. When we're born, that seals up, but the problem with that sealing up is it scars in, and it creates this pivot point that's just past the hook of the aorta on the very most proximal descending aorta, just past where the left subclavian takes off. So you've got all your great vessels going to your brain and upper extremities, tethering you at the top, and you've got the ligamentum arteriosum tethering you at the bottom, and that's a really high strain area, and a really high percentage of people tend to injure their aorta right at that area. Compression injuries are also, so again, this is a patient with sternal fracture, bad rib fractures, and so you can kind of see the cave-in pressure of the chest. The bottom patient is obviously a horrible spinal fracture with the aorta marked with that star in the bottom left quadrant, and you can literally see the spine pushing into the aorta there, and the CT with that, again, showing these luminal irregularities within the aorta on the bottom right where the aorta is injured and compressed. Finally, and this is for the other mechanism for blunt aortic, this is my favorite study. Just the things we used to be able to get away with and the people that thought of this. So they decided to do a study on what pressures the human body experiences. So the way they did this was they took cadavers and they filled up the vasculature, if I remember, with saline or with fluid, and they put them in. They replaced the crash test dummies in the crash test models you've all seen where cars get driven into walls. They put cadavers in there with aortic pressure monitors in, and they literally took human cadavers and slammed them into the wall and measured their intra-aortic pressure, and it shot up to 500 millimeters of mercury, right? So we think about hypertensive crisis and emergency at 200 millimeters of mercury. Now we're in that moment in these, 50 to 100 milliseconds of a front end collision. And again, these were relatively reasonable speeds. I think they did it at like 30 miles an hour. The intra-aortic pressure jumped to 500 millimeters of mercury. So just that intraluminal pressure alone can tear the aorta. Um, a more recent study out of the LA County group that looked at blunt aortic injuries of patients that had blunt aortic injuries, more than half of them were from MVCs, a significant portion from autoped, a smaller percentage from motorcycles, and a smaller percentage from falls. Again, some of this mirrors the overall rates of these injuries. But any of these trauma mechanisms can lead to aortic injury. I will say before I go on, the aorta, if the aorta is completely transected and not contained, these patients die in the field, which is again why there's a decent percentage of field deaths that are from blunt aortic injury. Because if you lacerate, tear, rupture your aorta and it is not in some way contained, you bleed out your entire blood volume in the matter of half a minute to a minute and a half, right? Like your blood is gone and you are dead, and it is very fast. So by nature of a patient showing up not in trauma arrest there and having an aortic injury, that aortic injury almost by definition is contained in some way. And so then our job is to not break what the patient's body is trying to keep contained. And the big way we do that is pulse pressure or impulse control. We know that the tension on the aortic wall is directly proportional to the blood pressure and inversely proportional to the pulse rate. So the faster the heart is beating with every pulse in the aorta, the more pressure we're putting on the aorta, and for obvious reasons, the higher the blood pressure, the more more pressure on the aorta. So this can be controlled medically. So we do pulse pressure control classically with an esmolol drip is good at controlling the heart rate. But we also don't want these trauma patients to be massively tachycardic or in horrible pain reflexes and their blood pressure jumping up to 150s 160s, is that can take a aortic injury that is contained and could lead to a free rupture that's going to lead to very, very rapid demise. So good pain control. And if we know these injuries, which in the field and from the initial, you won't know these injuries, but I'll loop back to this a little bit of when we talk about damage control, resuscitation, but a low blood pressure alone is sometimes protective in trauma. And so none of us love seeing blood pressures in the 80s or 90s in a trauma patient because we're worried they're teetering and about to drop off a cliff because they're bleeding. But there are situations, and I'd say in trauma, until we have hemorrhage control and until we've ruled out aortic injury, that I actually want a blood pressure of 80s, 90s, right? That is going to be protective from causing an aortic rupture, and also, as we'll talk about it a little bit later, about potentially limiting ongoing bleeding.
Dr. Wright, there is a question in the chat, really quick, just
Yeah,
about, I think, back on the penetrating trauma. But what are
yeah.
some strategies for estimating blood loss in the field? Since,
Oh,
and sometimes the patients aren't at their original site of injury. So, do you have any tips or tricks for how they can help report and estimate blood
that's
loss?
a great idea because I actually ask that often in somebody who's come in with big stab wounds or slashes is how much blood did you guys see? And I don't know other than the way I think about volume in the field, volume in general is, next time you're bored at at work, if you've got a tile floor, get a soda can, which is 355 millimeters, and spill it on the floor, right? And see what that looks like. I wish I had some scientific method to estimate that, but go take a known volume or a half liter of saline, if you want to do it that way, and dump it on the floor and see what it looks like. Because that is actually a critical question. And I'll come back to into hemorrhage control of one of the places patients lose blood is floor, street, etc. And I think it is hard for us to estimate, but it's a critical piece of information that I'll often ask the EMS teams when they're there is how much blood was at the scene. I don't know if that's the best possible answer, but that's how I think about it. Do a science experiment. Pour
That's
pour
great.
a soda can out on the floor, see what it looks like.
And then you have to clean it up.
Yeah, somebody's got to clean it up. That's what the junior person's for. Okay, perfect. Thanks for that one. All right, so management of these blunt aortic injuries. So conventionally, we used to treat all these with an open aortic repair, and we put people on cardiopulmonary bypass, and just like we do for an open heart surgery. The problem is going on cardiopulmonary bypass requires us to heparinize and thin the blood dramatically. What injury patterns do you think patients with aortic injuries often have? If you took enough force to your body to tear your aorta, do you think you took some head trauma too? And the answer is very frequently yes, right? So there's a high concordance with these high mechanism blunt injuries to having intracranial bleeding. And what's the last thing I want to do in a patient with an intracranial bleed is put them on blood thinner and anticoagulate them. So it was not a great way to try to repair people because we were having to put severely injured trauma patients, often with significant intracranial bleeding, on blood thinners, which sometimes went very, very poorly. So thankfully, in the more modern era, we have ways to endovascularly stent and not require high or long-term anticoagulation. And we can often, again, temporize this with the pulse pressure control I mentioned. So again, as long as we're not allowing their heart rate or blood pressure to shoot up, then we are allowing their body time to keep this contained. And we can even do this sometimes for days and do an endovascular repair a little bit more in a little bit more of a controlled fashion. We've given other areas time to recover. And there are small enough injuries that sometimes we never need to stent. We just do pulse pressure control, make sure that we give the endothelial lining of the aorta time to heal over again. We'll do follow-up scans, and often these injuries, these smaller versions of these injuries, will resolve on their own. So that X-ray on the lower right is from an aortogram where there's a wire up and they're putting a stent across. You can see that kind of at the crook of the candy cane off on the right there. That's where the aneurysm. You can see the wall kind of bulges out there, and that's being stented across. Flail chest. Let me see if this video. So this is where I said I'd come back to it. This was a video I got in the trauma bay many years ago. So it was on one of the original iPhones. So it's not the highest quality, but this was a lady who came in after hitting a center divider at a pretty high rate of speed. Actually, before I play that video, to understand the concept of what you're seeing, the concept of flail is that you have at least 3 ribs in a row broken in 2 places. And the reason that that's a problem is, as I was talking about earlier, when we are spontaneously breathing on our own, when we breathe in, we create a negative intrathoracic pressure. Our diaphragm drops, our chest wall expands, and you take a big breath. It's not that your lungs are pushing out your chest wall, it's that you're expanding your chest wall and dropping your diaphragm, and that's creating a negative pressure that actually pulls the lungs open. Now, and then the exact opposite happens when we exhale. The diaphragm comes up and the chest wall pulls in, and that forces the air back out of the lungs. Again, this is in the situation where we're spontaneously breathing. It's exactly the opposite with when you're intubated or bagging. It's because then we're actually forcing air into the lungs and doing the inverse process. But when we're spontaneously breathing, if we've broken 3 or more ribs in 2 or more places, we've now created an area where those segments of ribs in between the 2 breaks are dissociated from the rest of the chest wall. So now when we inspire on one side and the chest starts to rise, well, there's a whole segment of the ribs that are no longer attached to the rest of the chest wall. So that segment of the chest will actually collapse in with inspiration. And then when they breathe out and have positive pressure, that segment will then pop back out. First of all, it takes a lot of force to do that, and often the ribs themselves the lungs themselves are significantly contused, and they're likely to develop significant worsening of their pulmonary status in the first 24 hours. But what we'll often see, if this plays, is this pattern. Oh, is it green for you guys? Can you guys see that video?
It's green for
It's
me.
green. Son of a gun. Oh, that's such a shame. You can kind of see it even through the green, but if you, the chest wall kind of sinks on one side and raises on the other, and the other chest wall does the inverse, right? And so if you're looking at kind of the white spot where the kind of the nipple is on the patient's right side, if you I wish this weren't green. I'm sorry, this didn't show up. But see how the chest wall kind of sinks in, and that's when she's breathing in. And that whereas the left side of her chest is expanding because she doesn't have flail, the right side is sinking in. And when she exhales, so you get this almost wave effect where one side of the chest expands when the other side collapses, and that's when they're exhaling, and then when she breathes in, her right side of her chest gets sucked in and the left side normally expands, and so it creates this kind of wave effect. I'm sorry that video didn't show up. It's old technology. Now the other problem with this is, again, we have significant pulmonary contusion. Also, these patients frequently will need to be intubated. Initially this was with her spontaneously breathing on her own with some supplemental oxygen, was holding her sats, but even in the trauma bay within half an hour, she was on increasing oxygen requirements, which is pretty standard, needing to go to ward and needing to be intubated. Keeping in mind with this severe chest trauma that now putting a breathing tube in and forcing air into the lung, again with positive pressure ventilation, can turn a small pneumo, which is almost certainly has a pneumo with this degree of chest trauma, can turn it quickly into tension physiology. So having a chest tube in place is going to be helpful. So that paradoxical respiration was the video that I failed to show you successfully. I'm sorry. Finally, in chest trauma, cardiac tamponade, and we'll talk about this a lot more, especially in resuscitative thoracotomy. But cardiac tamponade is a very rapid killer in the trauma world. Thankfully, not real common, but also one of the few things that we actually can rescue somewhat efficiently with a resuscitative thoracotomy. But unlike in the medical population, where you'll see patients with huge pericardial effusions, right? And that's because that fluid has built over time. So the pericardium is relatively elastic over time, but with acute blood in the pericardium, it's fibrous enough that it doesn't stretch quickly. And so a relatively low volume of blood in the pericardium that happens acutely, as you would with shooting, stabbing, or even a blunt cardiac injury, can very quickly lead to cardiac tamponade, which again is the big, the multifactorial, but the big issues are when you have pressure trapped within blood, trapped within the pericardial sac. Now you're impeding venous return back to the heart. You're also impeding the ability of the heart to fill and squeeze. So the heart progressively gets more and more compressed to the point where you have cardiac arrest because the heart doesn't have volume returning to the heart, and even when it does have some volume returning to the heart, there's physically no room for the heart to fill and pump effectively. FAST has been life-changing for this because having an ultrasound where we can quickly look either subxiphoid or peristernal and see that there is fluid around the heart gives us a quick diagnosis. We can drain this surgically pretty quickly just by going kind of right under the xiphoid and kind of popping through the diaphragm into the pericardium and nicking the pericardium open and letting that blood drain out, which can then allow the heart to beat. So if they are not in arrest, if they're hypotensive, we can do that before they arrest. Pericardiocentesis is another option. Classically, fresh blood in the pericardium is, the textbooks say it doesn't clot. If you do this long enough, I've seen plenty of clotted blood in the pericardium. But in theory, a pericardiocentesis, putting a needle into the pericardium and then draining that fluid out, ideally leaving a drain, will again allow us to decompress that fluid in the pericardium and allow the patient to have a heart that now fills. Is not definitive measurement, but certainly we can put one in to temporize until we can treat this definitively. If we are going to drain, if we are going to put it, we recommend putting a catheter in, because again, there's blood in the pericardium for a reason, and it is frequently going to reaccumulate. So if you're going to drain it, try to leave a drain in place so that some of that blood can't escape. Again, it's not perfect. There will be some blood that clots in there. So, but it can often be temporizing enough to prevent an arrest. And then again, conventionally, the answer with this is if we find blood in the pericardium, do a subxiphoid window, then we're going to open the chest and open the pericardium and find the problem and fix it. There are some newer data out of, like a lot of other things we do in the trauma surgery world. People have found ways to not operate on things, which is sometimes a very good thing for the patient. There certainly are a subset of patients that we drain a little bit of fluid out, they clinically improve, we leave a drain or watch and no further blood is pouring out, and that whatever was bleeding has stopped bleeding on its own, and we don't necessarily have to subject them to a median sternotomy. But in general, patients that have pericardiocentesis are very likely, or have pericardial tamponade, are very likely to end up with their chest open one way or another, whether it's with a median sternotomy or sometimes a resuscitative thoracotomy, which we'll talk about. So again, ultrasound has been life-changing for this. So, bottom left is our classic 4 views of the conventional FAST, where we look for fluid between the RLL, or the right lobe of the liver, and the RK, which is the right kidney. We're looking where that white stripe is. There's no fluid in that. There's just a normal white stripe, which is not fluid, which is the boundary between the kidney and the liver. In the bottom left, we're looking between the spleen and the left kidney. Again, normal white tissue there, not blood, which shows up as black. And then the pericardial, pericardial view is that upper right. We're looking at right ventricle, right atrium, and the left lobe of the liver. And again, we're seeing kind of the boundary of the heart muscle in white, so that's normal. But then these with the arrows are all showing examples of positive pericardial fluid. So now we see right atrium, right ventricle. The asterisk in that upper picture shows us the fluid in between the heart musculature, which is bright white, and the pericardium, which is the thinner white line that the red arrow points to. Similar picture in that middle, where you can actually see it at the bottom, but you can see it wrapping all the way around both right and left ventricle. So a lot of pericardial fluid there. Sometimes it's more subtle, as in that bottom picture where there's just this thin fluid stripe. But those are all examples of positive pericardial ultrasounds. And most of us will actually start our fast with the pericardial window, because of all the things that are going to kill the patient fastest, other than airway loss, this is going to be the one that kills them the fastest. And then finally, to round out the fast, in that bottom right picture, labeled D, that's bladder, uterus. I don't know what he's marking there, but we're looking for fluid outside of the bladder, which we're not seeing. We're just seeing fluid within the bladder. All right, so hemorrhage control. So this actually ties, this is where I was going to tie back to that blood on the floor question. Hypotension in trauma is hemorrhage until proven otherwise. So the unstable patient, trauma patient, is presumed to be bleeding. I still to this day use this where somebody's sick and I'm struggling to figure out where they're bleeding. These are the 5 places patients bleed. They bleed into their chest. We talked through a lot of that. They bleed into their abdomen. They bleed into their pelvis or retroperitoneum. They bleed into their, out of their extremities or into their extremities, and they bleed on, people call it different things, street, bed, floor, right? So that's that external blood loss. Scalp wounds bleed a lot. Sometimes they're, we put them on chucks and don't realize how much they've lost because the chucks absorbs a lot of it, but you can lose a lot of blood. And that's part of the reason we're rolling patients and looking carefully for all the injuries. So there's things we can do in the field, right? So chest, we've already talked about. We can vent their chest. We can give them blood if we have it. One caveat I say is don't clamp chest tubes just because they're bleeding out of that chest tube or pigtail you put in. resuscitate them, and we'll talk a little bit about resuscitation, but resuscitate them, but clamping off a chest tube is not going to tamponade bleeding. The chest bleeding doesn't tamponade. So just because they're pouring blood out of their chest tube, it feels like we need to stop that bleeding, and clamping the chest tube is the answer, and in general, not the answer. Like, that blood needs to escape. We just need to give more and figure out how we're going to get that bleeding fixed as quickly as we can. Abdomen's tough. There's you put a trauma surgeon on a rig, and we're not going to be able to fix intra-abdominal bleeding, right? Like that. This is unfortunately needs an OR, needs all the resources that we have at a hospital to stop intra-abdominal bleeding. There's really no one's come up with a good system yet to even temporize abdominal bleeding from a mechanical standpoint. Pelvic bleeding, we can fix. We'll talk about binders. Extremities, we can fix. We'll talk about tourniquets. And then external bleeding, again, street, bed, floor, combination tourniquets, pressure, putting direct manual pressure, putting a dressing on the wound can limit that bleeding. So going to pelvis, because we've already kind of done chest, pelvic fractures are a huge source of bleeding and potential morbidity in trauma patients. So a lot of life-threatening hemorrhage is associated with pelvic fractures, and that is bone bleeding, arterial and venous bleeding, often coming off of the internal pelvic and internal iliac vessels deep in the pelvis. More commonly, venous being venous is a huge source. Arterial can be managed as well, and I don't really talk too much about the differences between pelvic packing and IR embolization, because that's very hospital specific focus, but there are things we can do in the field, right? So we want to mechanically stabilize and control bleeding. Pelvises break, and this is the way we classify pelvic fractures, but I also think it's helpful to think about the mechanisms that pelvises break, right? And so the classic analogy for a pelvis is it's a hard pretzel. Sitting around a bar or wherever you are and trying to eat a pretzel, a classic little hard pretzel. If you try to break a pretzel, you can't break it in one place, right? It's always going to break in two places. The pelvis is a ring, and so functions like that. Same concept. If you break the pelvis, it's not just broken in one place. So the LC fractures, or lateral compression fractures, are forces to the pelvis that come from the sides, right? And so you get these iliac wing fractures and kind of rami fractures, and the pelvis can be displaced, and sometimes markedly. The ones that scare us the most in some ways are the anterior posterior compression fractures. So that's the force comes from front to back or back to front of the pelvis, and the pelvis literally just kind of splits open, and often splits at the pubic symphysis. And this is especially bad from a hemorrhage standpoint, because once you split a ring open like this, it's not actually a ring, it's actually a cone, right? If you think of the pelvis in 3 dimensions, it's kind of a cone. You have a lot of blood vessels deep down in the pelvis, and when the pelvis splits open like that and a blood vessel is torn, which is fairly common, you've now markedly increased, the volume contained within that cone. So by letting the pelvis open, there's now a lot of bleeding and there's no pressure to control it. So this is why pelvic binders are really helpful, is it helps realign the pelvis and essentially splint the pelvis back together, and that decreases the volume that's in the pelvis, which is mostly retroperitoneal, and allows that blood to clot off because we're putting pressure on it. Vertical shears, kind of the other major mechanism. Falls, or even an MVC, if somebody has one leg braced for impact against the car, and so all the force is transmitted unilaterally through one leg and pushed up into the pelvis, you get this shear where the entire sacroiliac joint and rami fracture and shear upwards. These can certainly cause bleeding, significant bleeding as well, but really cause a lot of nerve injury for obvious reasons. All these little nerves running through this area are just sheared off with this force. But again, things we can do about it. The TPOD, or trauma pelvic orthotic device, is the one of a number of systems that are designed to replace the old sheet model. So Sheets work, and then certainly in the hospital, external fixators, orthopedic applied external fixators or C-clamps can work, but T-pods really work well. So this picture on the bottom is kind of a classic APC3 or an open book pelvic fracture, and you can see on the left side, back by the sacroiliac joint, you see kind of a widened gray space. That's where the sacroiliac is disrupted, and you can see the pubic symphysis is completely opened. Putting on the T-pod, bring the pelvis back together. Now the pelvis looks like normal anatomy, and you can see that the difference in area of hollow space in the pelvis and that difference in volume is even more dramatic. And I'll talk a little bit here. Do T-pods work? Yes, they work well. And this was looking at actually, again, external fixators, orthopedics applied, compared to a T-pod, and they worked equivalently as long as you apply them correctly. So one of the big problems with pelvic binders is they're generally placed too high. So we want to center them on the greater trochanters of the femur. So if you feel kind of laterally on your hip, you feel the trochanter of your femoral head, that's actually where you want to center it. Commonly, they're placed up over the iliac wings, so up higher where you can kind of feel the iliac crest. People tend to put them either too high, and they don't work as well to really close down the pelvis, and can actually make, if you have iliac fractures, you can actually dissociate them even further by having one that's too high. The other problem that we run into is even if they are applied appropriately, trauma patients are often in a lot of pain and are being moved a lot or are moving themselves a lot on the bed, right? So the moment that we let someone's legs splay open, even if our T-pod was placed appropriately over the greater trochanters, the moment their legs frog leg out, what happens to our T-pod? It slides, or our sheet or whatever we're using, it slides up and becomes an abdominal binder and isn't really working. So if you're putting on a pelvic binder, which again have a low threshold to put on because that can slow or stop major life-threatening bleeding, try to keep their legs together. If I'm putting on a binder in the trauma bay, I'll often grab a roll of tape and literally just kind of tape the patient's feet or ankles together. Especially if they're moving, but even just to kind of remind us as a team, like we don't want their legs to splay open because that binder will shift up and then not stop working, and then will not work as effectively. Peripheral vascular, when to use a tourniquet. So like many things in medicine, there's waves of popularity and trends come and go. We used a lot of tourniquets, and we hit a time in like the 80s and 90s where people started saying, wait a minute, like, are we causing blood clots? Are we causing unnecessary ischemia? Are we causing nerve injuries? We're hurting patients by putting tourniquets on them. And so tourniquets actually fell out of favor for a while. We really stopped using them. Because again, for some of these concerns about, are we causing more damage by putting unnecessary tourniquets on? The pendulum has swung back now, I think appropriately, and this was based on some military data. This was Holcomb's group that looked at Iraqi troops or troops in Iraq over 9 months, looked at a lot of patients with major limb trauma and patients that had tourniquets applied, and looked at a variety of variables and found that turns out putting a tourniquet on saves lives. Putting a tourniquet on early before they're in shock, patients have better survival. Putting a tourniquet on pre-hospital before they show up in the ED or in the triage facility, better survival and pretty significant rates, right? So this was one of the landmark studies that really pushed us back into, wait, no, we should be putting tourniquets on people. And a tourniquet that's on for half an hour is unlikely to cause significant long-term injury, but can absolutely be life-saving. So I mentioned I was going to come back to this damage control resuscitation, and this is another relatively modern concept, which is realizing that until the last 100, 150 years ago, when we had ways to surgically stop bleeding, the way we survived as a species is we bled a lot, our blood pressure dropped. That allowed more time for clotting factors to form, and it allowed our body to try to clot off potentially life-threatening injuries. And it turns out that slamming a bunch of crystalloid and blood into people is likely to cause more bleeding. We're kind of trying to undo what the body is naturally trying to do. And so this concept of permissive hypotension, like I mentioned, none of us love a blood pressure 80 systolic in a trauma patient because we're worried they're tipping over the edge. But actually tolerating that until we can get definitive hemorrhage control may be, and we think now probably is, protective. So part of this is with the shift away from slamming everyone with a ton of crystalloid, getting people warm. This was based on, again, wars tend to lead to a lot of advances in medicine, and then the Iraq-Afghan conflicts really showed this well, that we really want to kind of slow down our resuscitation, maintain perfusion of the body, but not drive to normotension, and perform this kind of balanced resuscitation. So again, one of these landmark studies that looked at pre-hospital into hospitalization patients that were hypotensive, systolic of less than 90, a more conventional treatment where we slammed them with 2 liters of fluid and then kept giving them fluid to keep their systolic blood pressure over 110 versus let's not do that. Let's just give them a little 250 milliliter aliquot and then give them small aliquots of 250 cc's, again, less than a can of soda, just to keep a palpable radial pulse or a systolic over 70. And it wasn't powered to show the mortality benefit with only 192 patients of 15 versus 5, although that looks like a big number. They didn't have statistical significance. But just looking at the blunt patient population, it did. It showed that the mortality benefit was significant, and a pretty marked 17.7% in patients that got 2 liters and slammed into normotension versus patients that were allowed to be permissively at a lower blood pressure had better survival.
Dr. Wright, there's a question in the chat really quick about thoughts on freeze-dried plasma.
I would love it. I've been hearing for literally the last 10 years that we're finally going to get it in the US. When I deployed with the Army overseas and we got to use it, and it's phenomenal. It is there, to my knowledge, has not yet been an FDA approved freeze-dried lyophilized FFP in the United States. The French have been doing it forever. There's a number of European countries and other countries throughout the world that have shelf-stable freeze-dried FFP. And it would be phenomenal if we could get that to our EMS partners, because it does last a really long time. And I would much rather patients be getting FFP than crystalloid. But unless something's changed in the last year or two that I've missed out on, I still don't think. I mean, when I was deployed in 2017, the rumor at that point was like, oh, they're trying to push it through the FDA and we'll have it on the market within the next 1 to 2 years. And that was now 9 years ago. So if you've heard about a way to get it in the US, let me know, because I want to get it out there. I think it would be great.
Great, thank you.
No problem. So this is another study again with Holcomb, and looking at patients that kind of got conventional resuscitation versus this new damage control resuscitation, which focused some on the blood ratios that we also learned that I'm not getting into in this talk, but focused on some newer protocols. But so they focused on better blood resuscitation, but also less crystalloid, and allowing this permissive hypotension, really showed the benefits of the kind of this new model of trauma resuscitation, where we're focusing on where we're getting much better survival, for 24-hour survival, but also 30-day survival and lower rates of acute renal failure and ARDS and the long-term ICU complications. All right, trauma arrest. And again, I struggle to go into a lot of detail with trauma arrest, but we can kind of talk through some of these points. In general, the survival is very poor. Treatment pathways are different than in a medical arrest, but overall, if you've arrested either in the field or even in the emergency department after arrival, overall that portends a very poor mortality. Studies will quote anywhere from 5 to maybe 12.5%, 14% at the very upper limit. And a lot of these studies are plagued with, are we ignoring patients that were called in the field, and are we really capturing the true denominator? And to be honest, I think most of us kind of don't believe even the kind of 8 to 10% series that we have as many survivors as are claimed. We do know in the big series that patients that arrest in the field have an incredibly high percentage of either severe life-threatening hemorrhage or profound TBI. So even in patients that survive, outcome issues become a critical issue, and I'll talk about that a little bit with resuscitative thoracotomy. A lot of these trauma arrests are in the pre-hospital setting. So again, like 2/3 to plus of arrests are pre-hospital, and the ROSC rate for pre-hospital trauma arrest is very low, 15 to 30%. The causes that we potentially can address are hopefully things that we've covered in this talk, right? So how are we going to get hemorrhage control? Are we going to put our binder on? Are we going to put our tourniquets on? Have we decompressed their chest? Have we given blood? Hopefully, if we have it. Again, crystalloid has not, when people have looked at giving crystalloid in the field, it doesn't improve trauma arrest outcomes. The things that do improve are getting some kind of an airway. It doesn't have to necessarily be a definitive airway, but getting some way to control airway, stopping bleeding, decompressing the chest, and giving blood if available. Chest compressions have not actually been shown to improve benefit. It doesn't mean you shouldn't do them, but really focusing on trying to address the reversible causes, knowing that external chest compressions are not going to bring someone back from a trauma arrest unless we've addressed the underlying reversible causes. Interestingly, epinephrine I put as kind of a controversial topic. Give a lot of epi in medical arrests. In the trauma literature, it actually has not been shown to improve survival, and in some studies actually worsen survival. It's not going to kickstart somebody back to life that's dying from TBI or from massive hemorrhage. So there's actually been more and more of a push to say, should we even really be doing epinephrine in traumas? The one thing that we do have in our pocket for traumatic arrest is resuscitative thoracotomy.
Really quick, Dr.
Hmm?
Wright, there's a question in the chat a little bit about transporting trauma arrest patients for the concept of organ donation. And are we leaving life-saving organs in the field?
Generally, my answer, it's a great question. I would say no in general. We are unlikely, because the rate of getting ROSC back. So if we want to actually maximize organ procurement, speaking hypothetically, theoretically, right, we would want to get ROSC back. And then what damage with a sustained downtime has that been to the organs, and what is the resource utilization to actually get someone back? And there's a lot of ethical, moral dilemmas there that I won't even touch on. But I think it's relatively unrealistic to expect that we're going to transport somebody and get ROSC back enough to be able to offer donation after brain death organ procurement. There is the concept of donation after cardiac death organ procurement, but that is in a very controlled setting that these patients aren't in, and we won't have time to work up organs, et cetera. So I would say no in general. Exceptions would be cornea and skin and things like that. There are some potential things that we can get post-mortem, even in a trauma arrest, but we're not going to be talking in general in those patients about getting heart, lung, kidney, liver that are going to be the truly rare organs for procurement. So setting aside the ethical and moral issues, which is a whole nother talk, I would say no, in general, we shouldn't be doing it for that reason.
Thank you. And then thoughts on applying defibrillation pads in a traumatic arrest?
It's a very low rate of shockable rhythms in trauma arrest. Most trauma arrests are either asystole, or PEA arrest.
It's okay.
So
You're a surgeon. We didn't
I
expect you
know,
to be able to pronounce
I'm
those
also an
words.
intensivist, so I don't know why I said that. But the vast majority, it's a very low rate of like VFib or other shockable rhythms, like 5 to 10%. So if it's not going to interfere, sure, I'm not going to say it's wrong, but I really would focus a lot more on fixing the reversible causes, because the percentage of shockable rhythm arrests are very, very low. Resuscitative thoracotomy, the best chance, as I mentioned, I'd come back to pericardial tamponade, of all the patients that survive a resuscitative thoracotomy. So we'll talk a little bit about who gets resuscitative thoracotomies, but your best chance of actually surviving is if they have pericardial tamponade, and the majority of those patients are going to be penetrating patients, which is, again, probably why the penetrating trauma, part of why the penetrating trauma survival rate is higher. There is a truly dismal survival in blunt trauma. One of the key concepts that comes up in resuscitative thoracotomy is signs of life. And so the signs of life, that when we say signs of life, we mean they have any detectable blood pressure, whether by palpation or some kind of a reading of blood pressure, but palpable carotid pulse is a good marker for that. Any respiratory or motor activity. So if you see even agonal respirations or any spontaneous movement or movement to behavioral stimuli, that counts as a sign of life. Electrical activity, so again, not in PEA arrest, but if you could actually see electrical activity, or sorry, not, I guess it would be PEA arrest, but other than asystole, and any pupillary activity. So any of those markers gives you a sign of life, which does change a little bit our prognosis. I'll go through some of the studies, but briefly, a resuscitative thoracotomy, we make an incision from the sternum just under the nipple or in the inframammary fold along the fourth intercostal space. So that's the incision cut down. The star is the fourth intercostal space. You can see the rib outline below there. We're opening into that space, putting in a finichetto or a retractor to open the chest. Once we're in the chest, we're looking for pericardial tamponade. So we're seeing the pericardium there and the phrenic nerve running along it. If they're, we will frequently open the pericardium just anterior to that phrenic nerve just to prove that there's no tamponade physiology. And then the other thing that we can do is clamp the aorta. And so there's a few benefits there. One, it stops bleeding anywhere below the chest because we've stopped blood flow anywhere below the chest. But it also then can provide perfusion to the brain, because now all the blood that's coming out of the heart is going to just the upper extremities in the brain. So this is a clamp on the aorta. Again, can't leave it on indefinitely, but can hopefully buy us time to fix the problem. If the problem's in the right chest, we still open the left chest, but then extend across to what we call a clamshell thoracotomy, where we open the chest all the way across, and that gives us a really pretty unparalleled view into the entire thoracic cavity. But landmark papers, there's a lot of caveats to this. Again, this was one of the big papers. Peter Ree was military surgeon at that point. Overall survival in over a long period of time in a lot of institutions was quite poor, 7.4%. Again, better with penetrating, best with stabbing of the subtypes of penetrating, very poor blunt survival. Where we got injured mattered as well. So again, patients with heart injuries or chest injuries had a better chance of being resuscitated versus abdominal injuries or polytrauma, which is unfortunately really common with blunt, but with multiple shootings or multiple stab wounds or body cavities injured with shootings or stabbings, we see as well. And then signs of life really mattered. So again, if you showed up with signs of life in the ED, your survival rate was better, still bad, but better, versus no signs of life in the ED and even worse in the field, right? So if no signs of life in the field, best case scenario, even if this was a pericardial tamponade, your survival would still be 1.2%. Another big study, that one of the true landmark studies on this, was looking at over 1,000 or close to 1,000 emergency department thoracotomies, which we also call resuscitative thoracotomies. And again, finding just the survivors over 26 years, 1,000 patients, only 26 people survived in 26 years. And again, the ones that survived tended to be stab wounds with GSWs and blunt at a much lower rate. The only people that survived with asystole all had stab wounds to the heart with tamponade physiology. And importantly for this study, there were no neurologically functional survivors with blunt trauma that had over 5 minutes of CPR. So if you had more than 5 minutes of arrest, you did not survive in any meaningful fashion. Even if we got people back, they were neurologically devastated and no meaningful survival there. So that is... So again, kind of in more recent summaries, hypotensive, the success rate, hypotensive with detectable vital signs, maybe can be as high as 14%, no vital signs, but some sign of life has maybe an 8%, and no sign of life 1%. Overall, big studies looking at a lot of different studies. More details there. I'm not going to belabor. This is the algorithm, the Western trauma, which is one of our big trauma societies that I think has the most kind of reasonable and rational algorithm that kind of talks us through in a reasonable way. So patients, and to be clear, we're talking a lot about trauma arrest. There is an indication to do resuscitative thoracotomy in the profoundly hypotensive patient who has not arrested yet. So a blood pressure of 50 or 60 systolic, we will sometimes do a resuscitative thoracotomy, and those often will have better outcomes. But if you're requiring CPR and no signs of life, the cutoff for the Western trauma is 10 minutes of CPR with blunt trauma or 15 minutes with CPR. A lot of places, and our institution, for instance, still uses the 15 minutes of CPR with penetrating trauma. A lot of us are using more of the 5 minutes of with blunt trauma because the blunt trauma outcomes are so horrendous, and there's a lot of risks to provider exposure from doing these heroic procedures. The risk of needle sticks or sharps or ribs fractures cutting through people on the medical team is relatively high. I've heard it quoted anywhere from 10 to 40% of resuscitative thoracotomies. Somebody on the team gets a blood exposure because they are fast and messy, and there are broken bones and broken ribs. So those are kind of our cutoffs for when we would consider doing resuscitative thoracotomy, which is really hard because often we get patients that are brought in and they're in trauma arrest, and that timeline is really critical to us. Did you, when you arrived on scene, were there any signs of life? Did you have an initial blood pressure and then lose it, versus you showed up on scene and never had any signs of life, never had a pulse? And those really determine what we're going to do and where we're going to go from there. And the really that kind of 5 minute for blunt or 15 minute for penetrating trauma in a number of studies, if we're outside of those time limits, patients do not survive or survive with any meaningful outcome. So it is not worth the risk to us. So I'm going to try to wrap up. So both the mechanisms of traumatic injury and where the injuries happen are key to our treatment of our traumatically injured patients. We really want to focus on these early life-saving trauma interventions, control bleeding whenever possible. And we've talked about a lot of ways to do with that. Use the tools we have, control the airway, decompress the chest, do a limited resuscitation, and get rapid transport. Traumatic arrests have exceptionally high mortality, except in kind of these limited scenarios that we've talked about. I probably did not leave nearly enough time for questions, and I apologize, but this is our trauma patient population. And I'll put up the QR code. I'll leave that up for a few minutes before I shut it off. So what questions did I miss?
I do think you'll have to check the chat. I'll be totally honest because I am driving the
Yeah,
kids to dinner.
cat. Trauma arrest for Oregon. Great question. Defib pads. All right, I'm scrolling. Oh yeah, I like the idea of take a picture and share it. Hospital. Okay. All right, I don't see anything new popping up. Sorry I ran a minute over. Thank you all for your attention. Link to the forum in the chat. Let me see.
Yeah, Frank, it's in that email I sent you. I think you can like copy and paste really quick if you can the link that Dr. Farkas sent for the QR code. She usually does the QR code, and then we put the
Got it.
link in case someone's watching on their phone.
Got it. Putting it in now.
Thank you so much.
Chat. I hope that's the right one. I just pasted it in.
Any comments on combat gauze and IT clamps?
Combat gauze is great for direct pressure maintaining. I didn't go over like junctional injuries, which are a lot more challenging because you can't tourniquet them. And again, we don't have a magic bolus. Ooh, I saw a TXA as well. What was the IT clamps? I don't know that I know that one. Did you say IT clamps? Is that right?
Yeah, I'm not sure we're using them much anymore. They're just, I don't know, they look like a hair barrette with needles on them to close a say an abdominal wound, maybe after combat gauze.
Huh, interesting. Okay. Yeah, I don't know that I've
And I think
seen
there's
those.
also you talked about junctional. There's, I forget what the name of the item is. Maybe somebody else on here um, understands it looks like a pelvic binder, but it does pressure on the abdomen and in the
Like
arteries and
the
Almost like,
junctional tourniquets.
yeah,
yeah,
the
I can't remember what the name of it. Yeah, the acronym is, but yeah,
Yeah, I've never seen good
come across
data that
that yet.
suggests those are incredibly helpful. I've seen a lot of different attempts and variations of people trying to figure out. And yeah, there's even like even an abdominal binder system that tries to put extra abdominal pressure, and have not seen any data to suggest in that those are helpful. And I mean, the problem with ongoing bleeding is in the abdomen is once you're trying to compress to that level, you're dropping your preload back to like it's kind of a vicious cycle, and there's no kind of direct manual pressure you can put on the abdomen. The junctional, there are some models that are kind of like fem stops that we use in the hospital that try to have like a balloon that blows up, up in the
Mhm.
axilla or the groin most commonly, that try to put some direct pressure, but they're not very good, is my bias on those, and I haven't seen data that support their use and
Yeah,
what
I've
that
seen
works.
just kind of seen the advertisements for them, and I think we were told, I was just like, well, we don't think that's worth the expense.
Yeah, and thankfully they are relatively uncommon. Yeah, SAM tourniquet that somebody put in. I do think there is a SAM tourniquet that kind of functions like that. That one sounds familiar. TXA is a whole. I could talk for 10 minutes on that, but um, long story short is I think with any extended transport time, I think TXA is very reasonable. The data is not perfect on it, and the Crash 2 trial has a lot of flaws. But I think if you're not in an urban setting where you have quick access to a trauma center, I think it's very reasonable to do TXA. Um, if you're near a big trauma center that can, when somebody rolls in the door with a trauma, we run a TEG, which is a special clotting profile that can rapidly assess within, 5 or 10 or 15 minutes, do they actually need TXA? And then we'll give it then. So I would say, are pretty selective about it, because there are some concerns with giving TXA in patients that don't need it, with hypercoagulable risks, et cetera. But I think if you have any reasonable transport length of time, TXA is a good, safe answer. And in terms of procedures, interventions, I mean, other than I think the big push in the last like 10, 15 years of military medicine has really been on this kind of golden hour concept, which is just always setting up a way to address trauma within that first hour. And so it really is focused on timeliness of definitive interventions or even temporizing interventions. And I think that's probably the biggest change that I've seen in the military, is just really focusing on having surgical capabilities as close to people that are likely to get injured as possible.